Why have I quit my job? Why have I, bought a van? And why am I going to drive around the country? Well, I'm passionate about the idea that you need to be heard. And I want to stitch these stories together across the states. We're going to find the commonalities. And it's going to be really an amazing experience. And I look forward to you joining me on the jar. Good morning, everybody. Welcome back to Mental Health Today. I'm your host, Ken Stearns. Beautiful day here. I'm camping out in Pensacola, Florida, with an old high school friend. A beautiful day outside, just driving around and enjoying the morning. Sharing with my next guest, Jennifer, a little bit of the other fun stories going on in life. As life marches on, whether or not we wanted to. Life just kind of marches on. Jennifer, welcome to Mental Health Today.
Thank you. Happy to be here.
Yeah. So, great little video that you saw me commenting on, just putting together my van that I drove around the country with the JAR podcast, which led me to really see the mental health crisis that existed in people's homes. Just going, hearing everybody's story, 300 and some odd guests that I got to meet in their home, hear their story. Shocking for me, the level of mental health crisis that we had across the country as I went, visited almost every state. So I started this show to really learn what was going on and who are the professionals and what are we doing and what does the future look like. And I think the question I had, Jennifer's in an interesting space, the geriatric psychiatric care. Is that a kind of a pretty good? Okay. I'm so proud of myself. 14 months ago, I never would have gotten that out. I would have mangled that to death. So, and it's just an interesting space for me. We haven't had, Jennifer, anybody on that does expertise like you're doing. People that obviously care for seniors, but nobody dedicated in the space and has a real business in it. So, welcome to the show. Tell us a little bit about yourself and what are you doing today? Tell us about the geriatric care and what's happening.
Yeah, no, happy to be here and excited to have a chance to tell the story of our particular patients, which are
Yeah.
I would say the underserved of the underserved in mental health.
Oh, goodness.
There, yeah, there's no doubt about it. I mean, we're in a mental health crisis. So I'm
Yeah.
so happy for your
Yeah.
show to call attention to what we're dealing with in this country and for that matter, this world.
Yeah.
Um, no matter what subspecialty of mental health
Mhm.
anybody might touch, children's mental health is important, young adult mental health is important, serious and persistent mental illness is
Mhm.
important, all of that matters. But what we work on, specifically at Aventis, is geriatric mental health,
Yeah.
and it's, if you actually read some statistics, geriatric psychiatrist is the number one underserved physician specialty in the United States. There's nowhere near enough of us to take
Whoa.
care of the amount of patients that are out there.
And
Mhm.
and as I said off before we started, it's a tsunami of gray-haired people coming, right? I mean, I'm just
Absolutely.
guessing that's the number. I'm guessing that's what's happening.
Yeah, absolutely. And thankfully, there is more attention to mental health, period,
Yes.
and so
Yeah.
that helps to drive attention. But yeah, the tsunami, the gray tsunami, the silver tsunami, all of these things
Yeah.
that's been nicknamed before, about the baby boomers coming to age, needs all kinds of healthcare interventions. But obviously, my passion is the mental health side of things, and how mental illnesses that affect younger people don't just go away, when they get older. So we deal
Yeah.
with all of the traditional mental illness that you might deal with when somebody's younger,
Okay.
things like schizophrenia, bipolar, depression, anxiety, all those things are still present. They don't, unfortunately become cured, in somebody's younger adult age. And so we're dealing with all of that traditional stuff, but then we
Mm.
add on top of it a unique series of mental health challenges with cognitive disorders. And
Right.
so it's something that we have got to be paying more attention to.
That's a tough one, right? I mean, you add in a whole nother layer of challenges. And I think even for the patient, those are also like in some ways the worst challenges because that you can't do things or you're not as sharp or you get confused and you're like, oh, I'm confused while you're still cognitive. It's
Yeah,
got to be
absolutely.
tough
And
for
it's the
people.
number one reason that people wind up in long-term care communities, which is where we specifically focus. So,
Okay.
as opposed to brick and mortar geriatric mental health, of which there's not enough either, we've chosen to focus specifically on delivering on-site mental
Oh.
health services and primary care. And we could talk about that
Oh.
later. The integration, I believe very much in that, to folks that reside in long-term care communities. Retirement homes, assisted
Yeah.
livings, nursing homes, that sort of thing. Who again, are amongst the most, neglected and vulnerable patients in the country.
How did you get I know you're the founder, or one of the founders,
Mhm,
co-founders.
mhm.
How did you guys come together? How did you end up in this, how do you end up getting this kind of passion and then deciding to get together with another group of people to say, "Let's make a business. Let's go sir," because you obviously there's a need, right? Like you said, no, not many people are going
Yeah.
to the long-term care facilities.
Yeah, there's absolutely need, and truthfully, I kind of stumbled into it, in a lot of ways. Nursing home work is nothing any of us learn about in medical school. I mean,
Yeah.
not at all. I mean, and when I say neglected, I mean really neglected.
I
We're taught to work in hospitals, or we're taught to work in, outpatient sort of clinics and things like that. We're never taught to work in nursing homes. And there's a lot
Wow.
of people that
There's a
live in
lot like
nursing homes and nursing home-like places like assisted
yes,
living
yeah,
communities and
yeah.
things like that. And, it's unfortunate, but I kind of moved to a new state and found a group of individuals who were starting to do this kind of work,
Okay.
and I was like, "Okay, I think that's interesting to me," because I like geriatrics. That was, again,
Yeah,
something
yeah.
I had studied, and I didn't really love the work I had done in hospitals or outpatient clinics before for a variety of reasons. I wanted to spend a lot of time with my patients over time, like outpatients do,
Okay, okay.
but more intense, like the way you get to know your inpatients when you work in hospitals. And so in this way, we're very intense with our patients. We're in their homes. We see what their living environment is like,
Yes, yes.
whether it be a room in a nursing home or an apartment in assisted living. We see everything in a way I never did in working in outpatient psychiatry and mental health services. And so that was just the second I tipped my toe in that, I was just
Yeah, yeah,
fascinated with myself because I could get a better understanding of my patients. Again, whether it be traditional things like depression or these cognitive disorders,
yeah.
either way, you can learn so much more about these patients when you're in person with them,
I
in their homes and in their environment, and see their family photos or their fishing
yes.
trophy on the
Yeah,
wall.
yeah.
It sparks much better conversation than I ever could have with my patients in other settings.
That is really interesting observation, like, from interesting information, I guess, for me, as an observation from you. You are it and those are fun. Actually, some of these my mom was in an assisted living place for a good 10 years, and they're fun. Like, actually, they're kinda like these old people are just a ball of laughs. Like, they're actually really in certain spots, they're loving their life. And I
Mhm,
think some of those people that get there, and they're kind of fun places generally. They're
mhm.
they're old, they got stories, they don't I had this my favorite mom story is the old 3 or I guess it was 4 of these older ladies sitting around having a lunch, and they started having a bit of a go at each other. A little bit of that geriatrics, just a little bit aggressively not nice to each other. And it was going around, it was a little spicy. And one of them just kind of giggled and laughed and said, "Oh, well, it doesn't matter. By the time we get to our rooms, we won't even remember what we said."
It's so fascinating the way people kind of lose their inhibitions. There's some neurologic reasons for that, like frontal
Right,
lobe dysfunction as folks get
right.
older. But yeah, there's a lot of just social. I just don't really care much of what people
No
think anymore kind of attitude.
no F's to give.
Yep.
She was so cute. She's like, "It doesn't matter." I was just mortified. I'm like, "How can you guys be friends? This is not like I'm sitting there at the lunch. This is like every day at the lunch table." They're like, "Yeah, by the time we're in our rooms, we take our
Yeah.
pills. It's all good. No one no one holds any grudges anymore." Um,
Yeah. So
yeah,
you've experienced it. I mean, it's a fun place to be. I
it's
mean, selfishly, I like being there too. And
I
I feel like I do a great clinical job. And again,
that's
these
so
patients had
nice.
nothing. These patients had nothing. If they were going to access mental health services, good luck. I mean, they would have to
Right.
be taken out in an
Get on the
ambulance
butt,
or
right.
right. It's an all day event. If they weren't confused to begin with, they're definitely confused by the time they come back. And it's very disruptive for them to have to access mental health care, and again,
I didn't even
probably
think about
can't get
that.
it anyway, but if they do, it's a 6-month waiting list, and it's very unavailable to them. And so it was just this perfect situation for me
Yeah.
personally because I liked it and they needed it. And so I just, it was just very natural for me and some of those individuals I met in
Hmm.
the beginning that stumbled into it too. And that's how the
Yeah.
business got started. It is the other co-founders are a primary care colleague of mine, another physician,
Okay.
and a psychologist. And we said, you know, any one of us can kind of go take care of patients in these
Yes.
facilities by ourselves and have a rewarding career because I was and I could. But if we teamed up together and developed a, you know, a
Ooh.
true model of things, a business of
Yes.
things that would take care of the whole person, that's part of our name, Aventis Whole Health, right?
Yeah, I
And
saw
take care
that.
of the whole person, from the medical side, you know, from the primary care side and from the mental health side, we could really change things, you know, and teach
Yeah.
people about this setting that I didn't know about, and this job that I find incredibly rewarding, clinically and personally. And we just need people to know about it so they want to come do it too. And so here we are 10 years later and 500 plus clinicians, and it's been quite a
Wow.
journey.
And how do you replicate yourself? How does that model work?
It has to do with a lot of, you know, finding the right people. So you have to have
Okay.
good sort of recruiting for people who have similar
Absolutely.
interests and passions.
Yes,
I'll
yeah.
tell you, it's hard.
I
Even though I find it a wonderful setting, not everybody likes
not
nursing homes, you know?
yeah, yeah.
So you gotta find people who might wanna do it in the first place, and then
Okay, right.
and then I'm also kind of a bit of an academic at heart too. And so we've developed at Aventus a very long, robust, detailed training program because
Okay.
again, this is not a setting other clinicians have been exposed to
Ah,
very much.
yeah.
So
Okay, so you need a
how do
good
you treat
onboarding
them?
program. Yeah. And
Absolutely.
and something under the franchise development that you've got, right? This kind of the event under the brand, the culture of the brand has gotta be the same approach.
Exactly. So that, you know, my
Okay.
clinicians in Indiana
Yes.
are doing a similar thing to my clinicians in North
Right.
Carolina.
Right.
And and the best thing, you know, the best thing that's available. And the truth is, Ken, there's not a lot of research to go by. You know, we don't have the robust, you know, NIMH clinical guidelines that a lot of other uh, populations have. You know, like how do we treat major depression? Now we kind of know that. How do we treat dementia? Mostly don't know. And it's kind of this hot potato that goes between, you know, primary care geriatrics and behavioral health and neurology, and everybody kind of takes a little bit of a turn, but it's a very, very challenging place to work because there's not a lot of treatments. And so you have to take into account psychosocial
Interesting.
stuff and behavioral health things to really enact a change for that individual and the family. The family is huge in what we do,
What a
Ken.
dynamic.
They
What a
are
dynamic.
it's hard on them.
I like the idea of bringing the primary care physician in as well. That
Mhm.
makes a lot of sense to me. What are you talking about that just looking at their medical records, or do they talk diet? So I imagine at the nursing care, like at that age, diet's gotta play a big role in how you're feeling
Yeah,
and even how your brain's functioning.
and exercise, I mean,
Oh,
all
exercise.
of the above. I
Yeah.
mean, and folks in these nursing homes, you know, don't get there by accident, right? So they usually have a lot of just traditional health problems, diabetes, heart disease, heart attacks, you know, neurologic diseases,
A
Parkinson's, all of
and
these
you're
things.
80 already. I mean, you're already gonna have some of
Right.
that.
Oh, yeah, absolutely. And so to try to tease out like the silos of medicine that I see even as a patient, you know, in the world, you know, where I might need specialty care from me or my family, nobody talks to anybody. You know, everybody kind of does their own thing. And and that's very disjointed and just in healthcare in general. I think that's really bad, Ken. And so we
It's
wanted to do much better for these patients and bring all that together. So the doctor who's taking care of their diabetes is in the same company as the
I
doctor who's taking care of their depression and their dementia,
yes.
and we're talking together
J j
every day.
It's so critical. I can't imagine trying to be really trying to manage on the therapy side when you don't see somebody's home, you don't see
Mhm.
what their car you don't know what their environment looks like, you don't know anything about their medical.
Mhm.
unless you ask,
Absolutely.
and then that's taking time away from, your time. It's really a great that's a great model, and I don't think, Jennifer, you've seen anybody doing anything like this in all.
I don't either. And that's
You
what
would
I
know
like
bet
to
I mean,
say.
yeah,
Yeah.
you would better know, but I've interviewed 140 people on this show in the space, a lot of different topics, but not much on maybe one other person on geriatrics, but
Mhm.
not like what you're doing.
Well, that's why I like to say that we've taken probably what was the most underserved population,
Yeah, yeah,
from either a primary care or a mental health side, to be
both, yeah,
honest.
yes.
And we've created this probably gold standard of the way, in my opinion, healthcare should be done in all settings. I mean, imagine if you could enter an outpatient office for yourself that had all of these services available under one roof, where everybody was working together and trying to do the best, for you in a very holistic way. I can't access it for my family in outpatient world, so
Yeah,
I think it's great.
I think one of my observations, and then maybe a frustration of learning and being on this side of the chair for so many listening to so many people, is kind of understanding that how much of physical health is due to the
Hmm.
mental health, and how insurance companies, it's shocking to me they haven't figured this out, to start, or hospitals to start to put, we need therapy or triaging people in a different way
Hmm.
at the hospitals when they show up, and start to,
Hmm.
we could reduce so much, stress related and other
Hmm.
related, mental related physical causes, by just helping address the mental health part of things a little bit more logically, not talking rocket science, this is
No, absolutely can. Stats show time and time again, more than half of ER visits are mental health related. And the
Jesus.
same thing is true for our population. More than half of a patient population in a nursing home has a mental health disorder of one kind or another. And the fact that they didn't have access to any specialists that could help with that is really astounding. And it led to
It's
some really bad things. It led to, overprescribing, sedatives, just because the
Oh,
primary care doctors are busy
Jesus.
doing a lot of things, right?
I know,
And so
I
what
know.
do? They just prescribe them things to calm things down and make the peace, in the nursing home. And that led to an epidemic of overprescribing, like, really heavy sedatives for these geriatric patients that probably didn't need it in the first place. And thankfully, actually, the government, CMS, kind of stepped in and put a big initiative together to start to get rid of some of those medicines. But folks like us are the ones that can come in and get patients on the right regimens and pay attention to all the behavioral health and the therapy side of things, so that maybe they don't even need the medicine at all if we can get things under control behaviorally.
I It must be for you guys, there must be some real shockers when you pull out the pill cabinet, when you get into the medicine cabinets from somebody and you're like,
Oh,
"What are what are you d why? And who's refilling
yeah.
this? And, how is this like, it must be a shocker in some of these places."
I mean, I can't even tell you. I kind of have a bit of a rule, Ken, because we all use electronic medical records, right? So we see the patient's chart on our screen, and you know how about the size of a computer screen. Sometimes when we take a new patient on, their medicine list goes past the size of the screen, and I have to scroll because there's so many
Jiminy.
medicines.
And you know that's wrong,
And
right? You just know
it's
that's
it's
wrong.
it's very wrong, and I can't tell you how many stories of, when we weren't in a particular nursing
Yeah.
home and they were kind of getting standard of care, and then we would enter, and it usually takes about 6 months to kinda
Yeah.
clean everything up and turn the place around. Patients start going home sometimes, I mean, because they are doing so much better, and, and I would see it. I would enter a nursing home, and again, no fault to anybody who was there before me because they just didn't have access to this kind of
They don't have
service.
access, yeah. Yeah.
And they'd all be sitting there kind of in the common area in a wheelchair and, head nods, half asleep all day. And we come in and we get things kind of cleaned up and teed up and get them the right, psychosocial treatments and everything. And then they're up playing bingo and enjoying their life again. And it makes me tear up sometimes. It's so impressive to see.
That would tear me up to come in and feel like, see,
Mhm.
really, it goes from, I'm trying to think of One Flew Over the Cuckoo's Nest. That's kind of the as you were describing that was the image I got. Just that hospital scene where they're all just sitting there, just absolutely medicated to death.
Mhm.
How, you know, you've seen this. I mean, but you're not the only smart person in the world. There's got to be somebody else in the room who's figured this out, that it's really a place of service. Um, are you getting any competitors yet, or not say competitors, but anybody else helping? Is anybody else helping out in the space, or
I mean,
how do
there's
we get more
some. I
people?
mean, there's some people who want to attend to, the medical care in nursing homes, and so there's
Mm,
a kind of a growing interest
okay,
in the primary care world of
in the
taking
primary
care of
care. Okay,
individuals in these settings, and, just like the hospitalist movement hit the hospitals a number of years ago, and,
yeah,
it used to be your family doctor would round on you. Well, that's long gone. Now we have dedicated people that work in hospitals. They're called hospitalists. Now there's this thing called sniffists. So SNFs is the short-term term for a nursing facilities, skilled nursing facilities, what it stands for. And
oh,
so now
okay,
there's a growing population of specialists that deal with primary care, and there's a dabbling around the country of folks who have entered the mental health space.
okay.
But really, nobody has put it all together, the way that we have, because it's
That's wild.
actually not easy. It's hard, and
It's okay.
trying to find the right clinicians and the right training and put all that together. Because back to what I said in the beginning, geriatric psychiatrists are the number one needed
Okay.
medical specialty in the coming years for this population, and there's not enough of us at all. So I go to conferences with other geriatric psychiatrists trying to solve that problem. Like, how are we going to
Yeah.
spread ourselves thinner, and how do we get access to more people? Or and I keep saying, well, I found some individuals to train, to get interest in this, and we do use a lot of nurse practitioners and physician assistants to help
Mm,
kind of extend the reach of our psychiatrists. And then we also partner with psychotherapists. So we have psychologists and licensed clinical social workers and mental health counselors that kind of are part of that whole integrated care team that help
yes.
me, instead of
Right.
just reaching, a certain number of patients, I can now reach a whole
Yes.
lot more, through a team like that. And that's
Yeah.
hard. So I think that's why not a lot of other people have done
I
it yet.
yeah, they're not getting in there. Yeah, that's interesting. You can train, like you said, train people, and especially once you start getting the processes down of when you when you onboard a new home, here's what you
Hmm.
do. You go in, you get the meds, you go through one by one.
Hmm.
So yeah, once you get that down, yeah, you can have other people do the screening, I'm sure. How do you guys
Hmm.
get paid? How does that work? How do you make this a business?
Yeah. So reimbursement in medicine is an ever-changing story,
Yes,
Ken,
that's
in
why I'm
general,
curious.
especially because, yeah, I mean, we're dealing with primarily a Medicare and Medicaid-based government insurer population. We have some, but we don't deal with a lot of Blue Cross or
Yeah.
that sort of thing. So that actually makes things pretty simple. We just have to play by Medicare's rules,
One
and
you just
things
have
work.
one. Okay, okay,
For the most part, yeah, and generally, Medicare is a great insurer, for our older folks in America. They do cover a lot of stuff, and they do
okay.
cover mental health treatment, and so we get paid just like any other doctor gets paid.
Super.
We see a patient, we send a bill just like anybody else does. The nursing home themselves doesn't, we're not contracted with them to pay us anything outside of a medical director fee that's a part of the primary care world, but that's not part of the behavioral
Okay.
health world. And so we're really just billing patients just like any other clinician does. And there's certain codes for mental health services that actually, again, Medicare has done a good job in the last number of years to bring attention to the crisis overall in the country for mental health and add services for seniors in mental health. And
Oh,
so
oh, that's very
that
good.
that has been helpful as well. And then all of it's building to, value-based care medicine where, instead of, this fee for service world that we've all been living in, but that's a whole nother podcast for another time that we can talk about.
Oh,
But it's exciting
value-based.
to me.
Oh, okay, well, we'll have to do that. We'll have to book that again. What did you call it? You called it value-based?
Value-based care. So, the 20-second summary of that,
Yeah.
Ken, is that, instead of being paid every time you see a patient, which is the way it
Yes.
works now, in most of medicine, that's called fee for service.
Yeah.
But value-based care is, instead of that, you're actually paid a set amount. Doesn't matter how much you see the patient, doesn't matter what you do, but what matters is how well you take care of that patient. Did you actually make the depression better? I don't care if you saw them once or 50 times. Did their depression get better? If so,
Whoa,
we'll pay you more for that.
whoa.
Did you actually keep the patient out of the hospital and therefore they cost less, to Medicare as a whole? Oh,
Ah,
we'll pay you some of that difference. That's called shared savings. And so there's a
Oh,
lot of movement, and Medicare specifically says that in the coming years, they're gonna require that all of their, members are in a value-based contract of one kind or another. One type is Medicare Advantage. Some people have heard of what that is, but there's other types out there, ACOs, that's what we actually participate with, and I'm proud to say, actually, we're doing really well. So, we're the number 1
I
performer in
I
the
bet you
ACO
guys would
program.
love this program.
Yep, we do, because we actually do make a difference. That's what's
Yeah,
exciting
yeah,
is,
yeah.
as most of the time as doctors, we're like, "Well, we think we're doing a good job,"
I
but, I mean, how do we know,
how do
until
you
somebody
know?
measures us? Yeah, and now we know, we've gotten it confirmed for 3.5 years in a row now that we are doing a good job, where patients are
Um,
getting better and they're costing less to the whole system, which is the gold standard that everybody's trying to
that's
reach.
that's an amazing result. And like I love the other one of people actually packing, looking around the room and going, "What am I doing here? I should go back
Yeah,
to my home, or I can go live with my
mhm,
kids for 5 more years
mhm,
as opposed to living in here." That to me, that's miracle level stuff. Getting out of the nursing
yeah.
home and going home. Um,
Yeah, and, even, even can outside of the, because there's lots of different people in nursing homes, right? There's patients that are in there long
yeah.
term, like the ones we've mostly been talking about, but there's also this, population in nursing homes, they're short term. They're only there because they were in the hospital for a little while, they need some kind of physical
Okay.
rehabilitation, and then they're planning to go back home anyway, but a lot of
Okay.
them don't actually make it back home.
Yeah.
But, statistics also show if you intervene with those people, the people that were only planning to be there for a couple weeks anyway, with psychotherapy services, and you give them counseling during their short-term stay, they have twice the rate of actually being successful to go back home. That's huge.
Whoa. So that is, I mean, that's just such a terrible thing to think about being, you find yourself landing in a nursing home because you've got a broken hip
Mhm,
and, 6 months later, they're talking about selling your house and just moving you in.
mhm. Ugh, every day I hear stories like that,
And that just would be
every
so
day.
like that's throwing you down the hole of depression right there. Like how do you get your head around that at 76 or 78?
Right. Yeah, even if they didn't have depression before,
Oh,
they
you you
the
for sure you're
geriatric
depressed.
depression itself. Yeah,
That's what I mean.
here's
That's
another
being
famous
kicked down the
quote is
stairwell.
yeah, yeah, another famous quote we say is, "The day that our patient got admitted to the nursing home was not the best day of their life." This is not the highlight of kind of their life story, so it's very sad.
That is tough, right? Like, even that is a bit of a mental health crisis. You need some
Mhm,
therapy. You need someone to talk. And your kids aren't gonna help. Like, your kids don't understand. They're not
mhm.
professionals. You can have all the love in the world and the best loving family. This is still a tough moment, right? All that stuff that you've been an adult and now you're no longer, you're back to childcare, basically.
Yeah, absolutely. It's
Yeah.
and that's why we have to intervene with the families too. I mean, it's so devastating. Just the social situation is devastating. There's so much guilt involved for the family for
Yeah.
not being able to keep mom at home, and we do a lot of counseling with the families as well. Who keep here's other sad stories. They keep coming to visit very advanced cognitively impaired individuals who don't even know who they are anymore, but they keep coming out of some sort of obligation or guilt, and truthfully, actually, sometimes rile the person up and make it worse. And I come in and I'm like, and I have these very honest conversations with my patients'
Oof.
families and talk to them about dementia and tell them it's just going to keep getting worse. Right now, I got very little I can do, unfortunately. And they're like, no one told me that it wasn't going to get better. I was like, no one told you it wasn't going to get better. Like,
You mean
that's sad. I mean, I think doctors can be chickens sometimes, and we're not honest with our patients and our families about what's really going on.
can't dem but I guess it's a like, I mean, I know the answer to that right away as soon as you said it, right? It's dementia. It's only
Mhm.
one way, right? Is that true? Only one way
For For most of the
for
kinds of
most.
dementia.
Okay.
Dementia is a catch-all term of a lot of things, the most
Okay.
common one being Alzheimer's disease, which most of us have heard of before. And right now, I mean, we can do things. I can do things, and that's why I believe very much in what we do to help with the symptoms or the maybe slow down the progression a little bit or make them more comfortable and less anxious with what's going on as they lose
Right.
their memory. but we don't have a cure yet. I follow a lot of research, and I actually am very hopeful that a lot of things will be coming up still in my career that I want to
Hmm.
be a part of. We even participate in some clinical research to try to help with that. But for right now, it's a this tsunami that's coming is going to create a second tsunami of kind of what this really means to the families and as they're kind of grieving their loved ones in these situations.
It's like a double death, right? You lose the person,
Hmm.
the body's there, but you lose the mind. You lose the person, the
Hmm.
memories, the stories, and then at some point you have to bury the physical body. That's oof,
Hmm.
that's tough. That's tough stuff to face. So I covered the money. That was an interesting one for me. This value-based care. We'll have to we'll have to come back and talk about that because I'm an a reformed insurance guy. And I did a lot of compensation work, a lot around compensation, motivation for people. So it's an area dear to my heart, understanding how people are paid and why they're paid and how to motivate people. And so I think it's great getting doctors on on results based care, basically.
Oh yeah, I am all for it. It's such a better system for everybody, including the doctor.
If they get their head around it.
Hmm.
Yeah, yeah.
Everyone's a little scared, but we're trying to be, ahead of that race on things. That's why we've been already participating for several years in a row because we're not going to have a choice soon, and I'm part of trying to usher that in because it's better for patients, and that's what I went to school for is to make things better for patients.
How'd you guys come up with Aventis, the name? It's got to be a story behind
Yeah,
that.
it's a great question. So actually, company I founded originally it was called On-Site Care. That's a very obvious name, right? But as we started to as we started to expand into other states, because we're in 7 states now, it actually was a name that was already used, and so we had to come up with something more unique. So we had to
Oh,
go down the
okay.
the branding route to get something
Okay.
unique, which we did, and because of what we were just talking about, because we really want to deliver good results to patients. We
Yes.
want to deliver outcomes, not just we think we're doing a good job, but we really want to prove that we're doing a good job. Aventis in Latin means results and outcomes. And so that's where
I
the name came from.
okay. Yeah. I googled the Latin on it and I'm like,
Mhm.
okay. Makes sense, but oh,
Yeah.
let's hear the story. I almost forgot to ask that question. I was like, I wanted to ask I was gonna ask it earlier and it totally just escaped me. But that's cool. That's so cool. I love the name, but that's a funny story. You had the
Yeah.
name and it's like such a practical name and go marching along and then, oh, okay. Okay. When you are you in all 50 states or is that the plan or not the plan?
uh, I'm ambitious. My partners are ambitious, so we
Yes.
want to be everywhere that patients need us. So I mean, I'll go to conferences and there'll be somebody in the audience from Guam who hears about what we're doing. They're like, "When can you come to Guam?" And I'm like, "Give me a minute." But right now we're in 7 states. So we started here in North Carolina.
Okay.
We're also in South Carolina, Kentucky, Indiana, Ohio, and we just merged with a practice. Again, there are some practices doing some of this, and now they're part of our Aventis family as well, and
Oh,
they're up
that's
in
great.
Virginia and West Virginia. So that's 7. That's 7 states in total right now. But we're looking at others.
Yeah, and I love that. The fact, I'm also big into, training backgrounds and bringing people up to speed and onboarding people and all that entails with that. So the fact that like you said, you're an academic and wanted to make sure that that was something you had as a practice, a business practice. I think it's great. The way to bring doctors on and make sure the care is the same from place to place. How do people find you?
So we have our website. Obviously, we're aventiswholehealth.com. We have a big LinkedIn presence as well. We
Okay. Oh,
post on there multiple times a week. Interviews with our clinicians, interviews with our customers. The facilities that we work
okay.
in and with. Various mental health topics, primary care topics that matter to our population. I'm on LinkedIn as well under the name Jennifer Rucci, so you can always anybody
Yeah.
can reach out to me that way as well.
I'll get you properly tagged in this post on LinkedIn. Jennifer, awesome
Absolutely.
conversation. Really nice to meet you and just pleasantly surprised the whole what you're doing is so cool. I really love it. I really love it.
Yeah, we love it too.
And you're making an impact. I really do believe this is a great model to take forward. And like I said, next time let's come back in a couple months and talk about the value
Sure.
base, or when it makes sense. I think maybe if there's maybe it's 30 days or maybe it's 90 days, or 6 months, whenever the model starts to get more flesh around it.
Happy to.
Okay. Hang on for 30 seconds, Jennifer. Thanks everybody for listening and supporting mental health today. It's great to have all these great comments. If you're listening on an audio version, still hanging with us on Apple or Spotify, drop down and give us a rating. Love to have those. Love to have more. It definitely helps with the show. Helps us stay relevant on all the different platforms. Again, Jennifer, hang around for 30 seconds. Thanks everybody.
Mhm.
Yep. Hang on. Try to launch my. Hang on.
Yeah, loose, baby.
But we're about to go and make this vessel with these great professionals at Public Glass. We're not part of the community, but we're from the outer family of glass blowing. Yeah, we're gonna go make a magical giant jar with optic lenses so that if you turn it, it changes all the time. So if you change the way you look at things, the things you look at change.
Hang on one second, Jennifer. I got a little something wrong with my laptop. It's just taking a moment.